Hello, everybody. Thank you for joining us for today's webinar. My name is Dana Burnett, Executive Director for WorldLink Medical, and I will be introducing today's event. Instructions for obtaining CME information will be provided on the same page as this video is listed. This conference is brought to you by WorldLink Medical. We provide evidence-based CME accredited education in preventive medicine and age management with a focus on bioidentical hormones. This webinar is supported by an educational grant from Acela Pharma. Our speaker today is Robert Morgan from Kingwood, Texas. Robert has been a nurse practitioner in acute care for the past 17 years. He is also certified in bioidentical hormones and has been doing PRP injections for the past 8 years. Robert has been working with patients in preventive care and helping patients with obesity, diabetes, and cardiovascular disease, as well as hormone therapy. Please welcome Robert Morgan.
Hello, good morning. I just wanted to go over a few things real quick. I have a video I'd like for you to watch for just a second, and we'll start that right now. Now you're going to wonder, what was that about? And what it is about is that as practitioners, physicians and clinicians, all of us, we need to make sure we are expanding our knowledge base every day. When we talk about thyroid or hormones, this is not something that's traditionally taught in medical school. And to get out and learn this stuff, we need to go the extra mile to be able to provide our patients with the best care that they can get. When we talk about thyroid, the biggest obstacle in my mind is that we are taught the TSH is the gold standard. And we need to get back to the basics. First off, why do patients go to the doctor? Do they go to the doctor? Do they go to the clinician because of the lab work that they have done? No, they go because of symptoms. It's always been this way, whether it's coughs, colds, fever, pain, depression, they go to you because they're feeling bad. Yet when it comes to thyroid, clinicians always fall back to the numbers. And why is it? The TSH. The TSH was never intended to monitor hypothyroidism. It does not correlate with thyroid symptoms. We're going to identify the complications of hypothyroidism. We also identify methods to assess the free T4 and T3 levels and optimize thyroid doses to alleviate and control symptoms of hypothyroidism. Now, hypothyroidism is poorly defined and treated by medical practitioners. And examination of what's taught in nursing and medical school reveals there's absolutely no emphasis given to the treatment of physiologic aging and the inevitable decline in thyroid function. High-dose thyroid has been used since the 1930s. It's a safe, effective therapy. Hypothyroidism is poorly defined, like I said, and not taught in medical or nursing schools. So education is extremely important postgraduate. Once you get out, you go to these conferences, you look at all the studies that are out there and try to learn the most you can. So let's talk about hypothyroidism for a minute and what are the dangers of not treating hypothyroidism. We want to describe and identify what hypothyroidism is, the signs and symptoms associated with declining thyroid levels, and at least 3 complications of untreated hypothyroidism. Remember that we're going to be talking about aging. We're not talking about a disease process. We want to identify a couple of major flaws of the TSH, describe TSH suppression, and identify the criteria to diagnose hyperthyroidism and the diagnostic tests necessary to make the diagnosis, including the TSH, the TSI, and by ultrasound or CT scan. We want to examine and identify differences between TSH suppression and hyperthyroidism and be able to differentiate between the two. We want the use of the free T4, the free T3 versus the TSH, and optimizing those levels to the upper half of the range to achieve symptom relief, which is what's recommended by the manufacturers of thyroid. So let's look at a few things here. Hypothyroid symptoms versus the TSH. This is a retrospective analysis that we did in our clinic here. We asked about quality of life scores, and prior to therapy, I had 192 patients that we questioned, and you can see the average quality of life score on a scale of 0 to 10, with 10 being the best, and of course 0 being horrible, dead. The average score was 4.3. Now, after putting patients on thyroid, we can see that the average score actually changed. It went up to 8.74. So quality of life is greatly affected by bringing your thyroid back to the upper half or upper third of the range. A final analysis was done on the population, as I said, and the score jumped from 4.3 to 8.7. We also looked at side effects. What are the adverse reactions, that were seen most frequently? The incidence of adverse reactions was minimal. If you look here, anxiety was reported in only 2% or 4 patients. Nervousness, nobody reported being nervous at all. Jittery, 3%, that was 5 patients. And the anxious and jittery could have been the same patients. Not quite sure about that, as this was a blind study, but palpitations were not reported. Irritability was 4% or 7 patients, and insomnia was 4%. So you can see that adverse reactions to thyroid are minimal. And if you do have them, guess what you do? You lower the dose. Just remember, patients seek treatment because they're suffering from symptoms, not because of an abnormal lab value. This is where we're always making our mistakes. And according to the traditions of medicine, the patient's symptoms should always be evaluated. Sir William Osler, who's considered the father of modern day medicine, said the good physician treats the disease, the great physician treats the patient who has the disease. So remember that thyroid replacement improves quality of life with minimal side effects. The initial symptoms of patients reported were not substantiated by an elevation in the TSH, yet there was a substantial increase in quality of life scores after treatment. We never looked at the TSH. We looked at the T4 and T3. This demonstrated that taking a preventative health stance to treat patients who are symptomatic appears to be safe and effective. Yes, this was a smaller study with 192 patients, but it was very telling. It's curious to note that 65% of the patients treated have been evaluated previously by their physician, family physician, or PMD. and were told that their TSH was normal and they did not need treatment at all. Yet they continued to seek help. They ended up here in the clinic, and after checking the T4 and T3, we did treat them. And they reported a significant benefit in symptoms with no significant risk or side effects treatment. So what do you do when you have a study and you want to make sure that it's good? You repeat it. So I repeated the study again. This time we only had 74 patients over the course of a year. And their symptoms were fatigue, weight gain, poor energy, poor concentration, depressed mood, thinning hair, hair loss, insomnia. This was a very, very similar study. And we'll look here. After 6 months on thyroid replacement, the average quality of life improved from 3.74 to 8.82. So 3.74 was the average of these patients, 74 patients. And as Neil Rozier likes to say, where do you want your numbers to be? All right. Like I said, all these patients here, they went to their PMD. They couldn't get treated. So what does it say about the perception of clinicians and the impact on the patient's life? 100% of these patients were told that their numbers were normal and that it wasn't their thyroid. Yet when I put them on thyroid, they all greatly improved. So is quality of life important? You bet it is. These are some of the comments included from the surveys afterward, and we can read through them, but feels much better overall, significantly more improvement. Night and day difference when I'm taking my meds. Thank you, thank you. Fatigue was a big problem before. Energy throughout the day is much better. Thank you for not dismissing my symptoms. Thank you for addressing my symptoms. I feel a million times better with thyroid treatment and wish I'd been diagnosed earlier. And of course, this goes on and on. I can't tell you how many hundreds of comments that I get from patients just like this. Let's go over the basics of thyroid for a minute. The thyroid keeps your metabolism under control through the action of thyroid hormone, which it makes by extracting iodine from the blood and incorporating it into thyroid hormones. Every other cell depends on the thyroid to manage its metabolism. The function of the thyroid gland is to take iodine found in many foods, convert it into thyroid hormones, thyroxine, the T4, and thyroid. Okay, we'll just say T3. T3 and T4 are then released into the bloodstream and are transported throughout the body where control metabolism, conversion of oxygen and calories to energy. The pituitary gland and hypothalamus both control the thyroid, and when endogenous thyroid levels are low, everything is slow or hypothyroid. When endogenous levels are high, everything is faster or hyperthyroid. And when it's actually hyperthyroid naturally, that's where we'll get into what's called autoimmune disorders such as Graves' disease. So what is T4? T4 is simply a thyroid molecule with 4 iodines. We're going to make that one real easy. It has 4 iodines attached. It's considered a prohormone, meaning it doesn't work directly on these cells on the cellular level. T3 has one of those iodines taken off, and it's a process known as deiodinization, where one of the iodines is removed. The T3 molecule is now active on the receptor sites. Testing has changed a whole lot over the years, but I do want to say the biggest problem with the testing, no matter how many new tests we get, is that the TSH is still considered the gold standard. How do you replace a TSH? It's not a thyroid hormone. The TSH is a pituitary hormone. So what can we do? We can check the levels. We can check the T4, the free and total. We can check the T3, the free and total. We can check the unbound or active versus the bound. We can look at antibodies like TPO antibodies, looking to see if the patient may have an autoimmune disorder that where the body's fighting the thyroid itself. You got to remember what we're treating. We're treating the actual thyroid hormones. And thyroxine or T4 is one of the two major hormones produced by the thyroid gland. And it's that small butterfly-shaped organ that lies flat across the windpipe at the base of the throat. So because of the location, you know, this thyroid can have quite an effect on your body that we'll talk about. The other major thyroid hormone, of course, is the T3. Remember, T4 makes T3, and together they help control the rate at which a body uses energy. Almost all the T4 and T3 found in the blood is bound to protein. The rest is free or unbound and is a biologically active form. So usually we're going to check the free T4 and the free T3. Okay, so this test measures the amount of free T4 in the blood, and 80% of what's produced by the thyroid is free T4, and then that T4 is converted into T3. It's said that this hormone is relatively inactive and is not active until it's converted into T3 through the liver and other tissues in the gut. But I have seen where you can have a low T4 and still be symptomatic. T4 levels are regulated by the feedback system that the body uses to maintain the thyroid in stable amounts. It's called a negative feedback system. So the more thyroid that is produced, the lower the TSH goes. T3 and TSH, along with its regulatory hormone thyrotropin or TRH, which comes from the hypothalamus, is part of the negative feedback system. And when thyroid hormone levels decrease in the blood, the TSH is supposed to go up in response to the TRH. So when the TSH goes up, it stimulates the thyroid to produce more T4. All right, so this negative feedback system is where the idea that the TSH actually mirrors what's going on, which is not true. When thyroid hormone levels increase in the blood, the pituitary gland produces less TSH, and the thyroid produces less T4 and T3. So when all these organs, the hypothalamus, the pituitary, and the thyroid function normally, thyroid function is regulated to maintain relatively stable levels of thyroid hormones in the blood. But as we get older, these levels are going to drop normally. And the TSH does not respond to a normal physiologic drop. The TSH responds to sudden acute drops. So you don't see the TSH go up in response to we're getting older and our thyroid levels are dropping. If the thyroid gland does not produce sufficient T4 and T3, we consider it underactive, and due to thyroid dysfunction or insufficient TSH, people will experience symptoms of hypothyroidism, such as weight gain, dry skin, cold intolerance. The hands and feet will be cold a lot of times. Raynaud's disease. I have seen many patients diagnosed with Raynaud's, and it's really just a low thyroid level. As soon as we get the thyroid levels up, the warm comes back. The hands and feet, you know, are no longer cold. So fatigue, that's a major symptom. So Hashimoto's thyroiditis is the most common cause of hypothyroidism in the U.S. And generally, as we get older, this tends to show up. which means that your thyroid's just not functioning like it used to. There could be some inflammation, but Hashimoto's, people get really excited about that. Oh, we got Hashimoto's. And we learn that by checking TPO antibodies usually. So if the thyroid gland produces too much T4 or T3, the affected person or patient will experience symptoms of an overactive thyroid. And that's going to be a rapid heart rate, anxiety, weight loss, insomnia, tremors, puffiness around the eyes, or we all see these bulging eyes that some of these patients have. So this is hyperthyroidism. This is an autoimmune disorder. It is not something that typically happens with thyroid replacement. And if it does, what do? You reduce the dose. But if it happens naturally and your endogenous levels are high, then what do we got to do? We got to treat this, because this can lead to strokes and heart attacks. And this is where we start talking about Graves' disease. Graves' disease is the most common cause of hyperthyroidism, and it is not something to be played with. In 18 years, I've only seen it twice. The patients were pretty much suicidal. They felt like their heart was pounding out of their chest. They were going to have a heart attack. Both of them were told that there was nothing wrong. And I remember this one fellow, he went to 2 different emergency rooms and was turned away. One of them wanted to put him on antidepressants, and he came to me, and I checked his thyroid with a local lab that was next door, and he was hyperthyroid. His T4 was like 16, which is really, pretty high. And I mean, this guy was about ready to have a heart attack probably. So we got him straightened out with beta blockers, and I sent him on to an endocrinologist. So remember that hyper and hypothyroidism can also both be caused by thyroiditis, thyroid cancer, or an excessive or deficient production of TSH. And the effect of these conditions can be detected and monitored by measuring the free T4. These are a couple of tools that I use when I'm looking at patients. You can see where at the top, I ask them what their quality of life is. And of course, we'll translate this into a numerical scale sometimes, but it's very, very important to see that we're making progress with the patients. And then I show the patients exactly where their levels are at and where they need to be. Apologize for that. So I highlight the upper third of the range. The manufacturer's package inserts will actually say the upper half, but I found that patients feel better in the upper third of the range. If you notice, there's not a place for TSH there. We do not check the TSH. Also, it may be a little difficult to see, but the thyroid screening tool that I use, you can see this patient checked everything. This was an actual patient. I just cut out their identifying information. But every patient gets asked this initially on the registration. And then when I start them on thyroid, every time we do blood work, I ask them to fill this same form out, and they can visually see the symptoms, what's still remaining, what's improved, and patients really love this. And if you look down at the bottom, this is the thyroid optimization treatment model that I use. I copyrighted this years ago, but it breaks down this very complex system into a toilet tank. Remember, I said it's a negative feedback system. And so you have your thyroid pumping T4 and T3 into the body, primarily T4. Remember, 80% of what the thyroid produces is T4. And T3. Now the brain's monitoring the levels, and when the levels go up and down, it is supposed to stimulate the thyroid or decrease the thyroid stimulating hormone on the levels. That's the premise of a negative feedback system. and that's what we're taught in school. Here's a little bigger version, and I actually put the notes down here where you can see how I treat. You optimize the T4 level. I read left to right. T4 makes T3. So if your T4 is low, I want to bring the T4 up. If the T4 is optimal and the T3 is low, then that's when I start to treat the T3. Okay, usually we're going to use desiccated thyroid, but you can give T4 and T3 separately and get a very fine tuning or control on the levels. The TSH, you got to remember, is going to drop regardless of what you give. If you give T4, if you give T3, the TSH will drop. If you use T4, let's say you're giving levothyroxine or synthroid or tyrosine, then you don't see the drop in the T4. Where you see the drop is when you give T3 or desiccated thyroid. If you give T3 alone, then you're going to see a tremendous drop in the T4. And if you're checking the TSH, you'll see the TSH drop. If you're given desiccated thyroid, that pig thyroid, then it combines T4 and T3 both. So you won't see quite the drop in the T4. Kind of complicated, but like I say, if you try to simplify it into this little version of a toilet tank I have here, it makes it a lot easier for the patients to remember. So what are some of the causes of low thyroid? Okay, they could be natural or not. Radiation, low iodine intake. Remember that the numbers, the 4 and the 3, are actually little iodines. Autoimmune disorders, medications such as lithium, thyroid surgery, very, very common nowadays, or an over response to hyperthyroid treatment. So if a patient is being treated for hyperthyroid many, many times, they will end up being hypo, and they will end up on some type of thyroid replacement for the rest of their life. Now, when we talk about the radiation, I want to talk about something that a lot of people don't think about. And this is very, very important in this day and age, especially when we have radiation all around us, like 4G and 5G. Okay. So can cell phones cause a problem? Can they make us stupid or cause cancer? Well, you be the judge of that, but the effects of radiation due to mobile phone use on thyroid function, I'm going to show you a study here that was done on medical students, okay? And the students were actually put on cell phones for anywhere from 15 minutes to an hour, okay? There was a significant correlation between radiation exposure and an increase in TSH. If you remember, I said that the TSH does not respond to physiologic aging. It actually responds to acute situations. So here you get on the cell phone, and that's an acute situation, right? So let's look at the slides here. So in 2017, okay, 2017, there was a sample size of 83 undergraduate students. 53% of the respondents spent half an hour on average talking on the phone. 28.9% spent an hour and a half daily, and 10.8% spent over 3.5 hours. And we found there was significant correlation between the radiation exposure and an increase in TSH in these groups. So if you look at the thermographic images on the left, you'll see this is before cell phone exposure. And then on the right, this is only 15 minutes. 15 minutes, and you can see the green has turned to orange and then red. And remember where I said the thyroid is, it's right there in the neck. So it's definitely got a profound effect. And how many times are you on your cell phone a day? So cell phones can actually cause a lot of problems. The next thing would be iodine intake. Okay, High iodine intakes associated with autoimmune disorders with the thyroid. A sudden increase in iodine intake or a sudden decrease, both of those can cause problems. People with anti-thyroid antibodies have a higher risk of developing thyroid dysfunction when iodine intake is high. So when you take thyroid replacement, are you taking iodine? You bet, but it's a little bit different than someone who's going out buying iodine or ingesting a whole lot of kelp or other products to try to raise their iodine because they read something, on Google. If a person has Hashimoto's thyroiditis, taking iodine only worsens the condition. It does not make it better. And remember, Hashimoto's thyroiditis is the most common cause of thyroid gland inflammation or thyroiditis. Okay, so we have to really be careful with these patients and ask them, are you taking, what supplements are you taking? Because a lot of times they don't even think, well, I'm taking this kelp. I got it over at Best Buy or wherever, Whole Foods, and they're taking all kind of things because it gives them more energy, but it actually is going to cause more problems, more bad than good. So exactly what is Hashimoto's? Remember, the thyroid's that small butterfly-shaped gland, beautiful little gland there in the base of the throat. It produces the thyroid hormones. We want to talk, remember where it's at because of some of the effects I told you it can have, like swallowing, voice. You can have voice changes. You see people with big goiters, or little goiters. You can look at people all day long and you'll see their necks enlarged and they just think they got a little fat neck, but usually that thyroid back there starts to enlarge as it's working harder, and you'll start to see this amplification. All right, and Hashimoto's occurs at a rate of 3.5 per thousand women a year and 0.8 per thousand men. So it's pretty common, actually. It can affect anybody at any age, but most often it's going to occur between 30 and 50 years of age. In fact, women actually are 10 to 15 times more likely than men to develop Hashimoto's. So, a lot of women are thinking they're just going through, menopause or perimenopause or gaining weight, when in reality their thyroid is starting to drop. 35 to 40 is kind of a magic number in my clinic. That's where I see the majority of my patients. They start coming in around 35 years old. People with a family history of thyroid disease, it's important to get that family history when you're talking to them. A lot of times you'll see type 1 or type 2 diabetes, adrenal insufficiency, rheumatoid arthritis, a lot of bone and joint pain, but RA is something that definitely points to low thyroid. Celiac disease, pernicious anemia, lupus, all these are an increased risk, and we need to really make sure that we're getting a good family history on these guys. So iodine, is it important? You bet. You ever wonder why it's in the salt? Adequate levels of iodine are required for the synthesis of thyroid hormones. And remember, the T4, the T3, those numbers are the iodines, which play key roles in the metabolic process of life. Major concerns regarding global burden of iodine deficiency are related to goiter, cognitive impairment, severe deficiencies. We're looking at cretinism. So the fortification of salt with iodine is an effective, inexpensive way of getting iodine to patients. Of course, now we're seeing a lot of kosher salt that's used, but the Morton salt out there, the iodized salt, is a very stable way to get iodine into the body. Iodized salt first became available in 1924, and we have what's called the goiter belt. Okay, and the government basically pushed this. It was initiative program to add salt. And the funny thing is they didn't know how much to put in. So when they first started this program, the whole state of Michigan basically became thyroid toxicosic. So some interesting reading in JAMA back in 1926. All right. This year, an estimated 52,070 adults, and that breaks down to 14,260 men and 37,810 women will be diagnosed with thyroid cancer. So thyroid cancer is the sixth most common cancer in women. It's the most common cancer in women 20 to 34 years old. And about 2% of cases occur in children and teens. I don't treat children, so not very familiar with those, but I do see, you know, some 20, 21-year-olds, even a couple 18-year-olds who have had, you know, some thyroid problems. And it's getting more and more common. And I believe that radiation, whether from our cell phone, whether from the 5G, maybe TVs, but radiation is definitely causing a big problem. The death rate for thyroid cancer has increased slightly from 2008 to 2017. And it seems to stabilize, but I'm really wondering, because here we are in 2021, 5G, and in 2020, 5G went up, and every conference I've been to has said that this is probably going to be a big problem. So we need to keep an eye on it. And why is hypothyroidism, why is thyroid such a problem now? I don't think it's because we're getting better at diagnosing it. I think it's because it's getting worse. Even though they said up until when I pulled this information for 2017, it appeared to stabilize. I'm seeing more and more patients. So, like I talked about, where the thyroid's located, just want to make sure you understand that. And it's really important to know, because, like I said, we see these fat necks all the time. Or people come in and say they lost their voice, or they're getting a little raspy, or they have a little cough, and you know, they're scoped, you look down, there's nothing going on. And it's because the thyroid sits on the outside of the trachea, and it can push inward. So they may not have any presenting symptoms other than, let's say, a cough. The funniest thing, well, it's actually sad, but my thyroid drug rep would come in. He's always clearing his throat all the time. And I would ask him, what's going on? Nothing. He went and got scoped. They said they couldn't see anything. And I asked him, I said, have you had your thyroid checked? And he's like, no, actually I haven't. I checked his thyroid, and his levels were extremely low. And so I started treating him, but then the cough didn't get better. So I sent him off to a specialist, and turned out he had thyroid cancer. So thyroid rep with thyroid problems and thyroid cancer. We always worry about nodules. And if you look at this picture here, the thyroid is made up of nodules. So when, you know, someone says their doctor told them they have thyroid nodules, you know, I don't get alarmed at that. The first thing I ask is, did they biopsy? Because remember, biopsy is a procedure, and it makes us money. But is it necessary to biopsy? I don't think it's always necessary to biopsy. You know, if you give thyroid and the nodules go away, was it a problem? No, it was because the thyroid's working harder. You don't want to miss anything, but in 18 solid years of checking thyroids, I am a member of ACE, and I'm actually qualified to do thyroid biopsies. I send them out to an endocrinologist if I'm going to actually have somebody biopsied. But you know, biopsies are done, I believe, more for economic reasons than anything. And it's real easy. Hey, we want to make sure you don't have cancer. Well, I'm going to tell you, after sitting through the classes at ACE and what have you, I wouldn't want any of those guys biopsying me, especially when they first learn. Um, so this is HPA axis, and you can kind of see the way it's described typically. And of course, this is the way I describe it. So I think the most important thing is trying to get your patients to understand, because when you start treating them and you're going against the grain, you're not looking at the TSH, you're looking at the T4, T3, everybody else is telling them they're normal and you're putting them on thyroid, it can be an issue. So you want your patients to be as informed as possible, and they're going to be your best defense. So hypothyroid complications, we'll go over those. There's quite a few, but we'll just list a couple. Okay. First off, high cholesterol. You can see that, triglycerides, metabolic syndrome. Something a lot of people don't think about is hyperprolactemia. This is a complication of hypothyroidism. And if you look in men in particular, we know women, you know, will start to lose their cycles, but when you have high prolactin levels, you can see a milk production. But look at men, impotence, galactorrhea, but impotence. Okay, can I say that enough? So maybe the impotence, you know, low sex drive and not being able to get it up, a lot of it could be related to elevated prolactin levels, and that is a direct result of low thyroid. We mentioned rheumatoid arthritis and checking the family history. That is a symptom, you know, of low thyroid. So subclinical hypothyroidism, metabolic risk factors. There was a study in northern Taiwan that was really good, and it showed that women showed significantly higher cholesterol, triglyceride, HDL, non-HDL, and HDL levels than those in the normal thyroid group. So women in the subclinical hypothyroid group showed significantly higher cholesterol levels. The prevalence of metabolic syndrome in the normal thyroid group was 26.4% in men and 18.7% in women. But in the subclinical hypothyroid group, it was much higher. It was 39% in men versus a 26, and 29% in women versus 18. So subclinical hypothyroidism definitely caused an increase in metabolic syndrome in this study. Prevalence of metabolic syndrome in the group, like I say, went way up in men, 26 to 39. You can see that. Now, this study shows prevalence of hyperprolactemia in subclinical hypothyroidism is notable. This disorder is more common in female than males, but there again, it is a big problem in both men and women. And in the Capsian Journal of Internal Medicine, they show that hyperprolactemia is associated with subclinical thyroidism, and demonstrated there was no correlation with a TSH. So the increased risk of thyroid autoimmunity and rheumatoid arthritis. This was a review and meta-analysis, and the results suggested that thyroid autoimmunity is more prevalent in patients with RA than in control populations. Meta-analysis was presented in Endocrine. Lipid profiles and different degrees of hypothyroidism. Study here concluded that hypothyroidism, subclinical hypothyroidism, leads to an intermediary lipid profile between euthyroid individuals and those found in that manifest hypothyroid, and that a significant lipid profile improvement occurred 1 year after T4 replacement. Now, this is something a lot of people don't really know, that low thyroid actually leads to an increased arterial stiffness and diastolic hypertension. And I have had patients who I put on thyroid and their blood pressure normalized, and in particular their diastolic. So when someone says, well, you're causing hypertension, you know, with the thyroid replacement, that's just usually simply not true. You're actually helping. Okay, so this study here actually was from the Journal of Clinical Endocrinology, and it shows that hypothyroidism is associated with increased cardiovascular risk and that it increases arterial stiffness, and it was reversed with adequate T4 replacement. So you have the endocrinologists themselves that are actually admitting that this is a problem. So if you look in JCM, you will find that article and many, many more. So in improving arterial stiffness with adequate T4 replacement is essential. The effect of subclinical hypothyroidism on blood pressure. Like I say, with the arterial stiffness, you're going to have an increase in blood pressure, and it's typically going to be your diastolic. Here's another study. This was in vascular disease management in 2016, and you can see they found the same thing, that patients with subclinical hypothyroidism are at a higher risk of hypertension and dyslipidemia. So, you know, just saying that your thyroid levels are normal is not going to help your blood pressure. It's not going to help your heart rate. It's not going to help that diastolic hypertension. We need to get these thyroid levels up in order to help, you know, give these patients some cardiovascular protection. Now, in JAMA, this was JAMA 2010, it was found that subclinical hypothyroidism is associated with a risk of increased risk of coronary heart disease events and mortality. So the risk of coronary heart disease increased with higher TSH. Now, remember, the TSH a lot of times doesn't go up that much with just physiologic aging. So, you know, with these patients, I mean, they were looking at TSH concentrations of greater than 10. And I'm going to tell you, I just don't see that many patients with TSH greater than 10. Most of them are around 1 or less than 1. Yet they still have very, very low free T4 and free T3 levels and are symptomatic. So subclinical hypothyroidism might increase the risk of transient atrial fib after coronary bypass. This is a study that had 260 patients who went under coronary artery bypass, and it was published in 2009, and the patients with subclinical hypothyroidism had a higher incidence of postoperative atrial fib than those with normal thyroid function. But the first thing that happens when you put a patient on thyroid, if they are found to be in atrial fib, is their family medicine doctor or possibly even their cardiologist is going to say, oh, it's the thyroid. It's the thyroid. The thyroid must have caused it. But reality is that's not what studies show. All right. This paper, like I said, demonstrates that subclinical hypothyroidism appears to influence the postoperative outcome for patients by increasing development of postoperative atrial fib. Levothyroxine. Remember, levothyroxine is T4. Levothyroxine treatment in euthyroid pregnant women with autoimmune thyroid disease. What are the effects on their OB complications? This is extremely important, and it's very tricky and controversial. A lot of people don't want to treat a woman who's pregnant. I have been in situations where, women will come in after multiple miscarriages. They've been to fertility clinics, and now they've gained weight. And so what do they want to do? They want to lose weight. So I start working with them. I eventually end up checking their thyroid. It turns out they have low thyroid. I put them on thyroid, and guess what? They end up having babies. But women who are positive for TPO or Hashimoto's develop impaired thyroid function, and that is what's associated with an increased risk of miscarriage and premature deliveries. Treatment with T4, levothyroxine, reduce the chances of miscarriage and premature births. However, I will tell you that even though the studies will show that T4 helps improve pregnancy, I have found over the years that most of the time it's T3 that seems to be the biggest culprit. And the problem is traditional endocrinologists have not been checking T3 levels. They check the T4 and they know the T4 is low, but they don't check the T3. And of course, your OB, they just don't know what to do when it comes to thyroid. So here we are. This is Circulation 2007 in the journal Circulation, Thyroid Disease in the Heart. Okay. And what did they find? Thyroid hormone effects on the heart and peripheral vasculature. Decreased SVR, increased resting heart rate, left ventricular contractility, and blood volume. Okay. Arterial compliance was reduced, leading to an increase in SVR, as well as a reduction in nitric oxide, a rise in diastolic blood pressure, low cardiac output, and a lower pulse pressure. So can there be complications of low thyroid, cardiovascular? Yes, of course. You increase that SVR, the heart has to pump a lot harder, the diastolic goes up, and of course, as most of us know, nitric oxide is very important. And when you have an impaired endothelium and low nitric oxide, then you're going to have even more problems. So hypothyroidism is often accompanied by a rise in diastolic blood pressure because cardiac output is slow, the pulse pressure is lowered, and like I say, there's an increase in that diastolic pressure. So when you see a patient and they have a 140 over 80 or 140 over 90 blood pressure, a lot of times it's really because of low thyroid. The increase in the diastolic pressure occurs when that low serum renin level is there and has to do with the sodium. Well, guess what? We can fix that. Thyroid disease in the heart. Again, this is just summarizing. Thyroid hormone decreases SVR and afterload. It increases renin and aldosterone secretin while increasing blood volume and preload, and contributes to the characteristic increase in cardiac output. So not only are we going to help lower cholesterol, we're going to decrease the diastolic, we're going to decrease the systemic vascular resistance, which makes the heart beat easier and more effectively. And this is all by itself a reason to make sure that your thyroid levels are good, because we don't want that associated cardiovascular risk that comes with low thyroid levels. The most common cardiovascular signs and symptoms of hypothyroidism may include bradycardia, diastolic hypertension, a narrow pulse pressure, a lot of times people, forget all about those pulse pressures, especially if you're not working in the hospital in the ICUs. But, if you look at your systolic and diastolic, look at that pulse pressure, you will see a narrowing, and that can be extremely dangerous. Cold intolerance, like I said, with the cold hands and feet, getting cold really, really easy, and fatigue, malaise and fatigue. Now, of course, with COVID going around, and a lot of people are fatigued already, and so you have to kind of differentiate. Always check the thyroid. If they're checking off all those symptoms, it's going to be a thyroid test in my clinic. So thyroid disease in the heart, overt hypothyroidism associated with increased SVR, decreased contractility, cardiac output, accelerated atherosclerosis, and coronary artery disease. In this study, they noted that given thyroid decreased SVR, like I say, after load, and ultimately improved cardiac output. They went on to say that hypothyroid patients have other atherosclerotic risk factors and an apparent increased risk of strokes, prolonged QT, and that treatment with full replacement T4 can and should be initiated at the onset. And approximately 30% of congestive heart failure patients have low T3. So there's that T3 finally. Now, when we're talking about full replacement, this is the manufacturer's recommended dosing 1.6 mics per kilogram a day, and that's a good starting point for people, especially when you're not real comfortable with thyroid dosing. Everybody wants to start on 25 mics, the lowest possible dose, and that's not what's recommended. 1.6 mics per kilogram is what's recommended. Some people can tolerate it, some can't. Some are a little more sensitive, but most of the time you actually need to go a little bit higher than that. But I will say the average dose that I see on T4 is usually somewhere between 125 and 150 micrograms a day. That doesn't mean you can't go higher. I mean, the doses definitely go higher, and we've seen in a lot of studies doses up around 600 and 800 micrograms a day, which is pretty high. But 30% of patients, I just got to stress, 30% of patients with congestive heart failure have a low T3. So we need to check those T3s. Don't check a TSH. Leave the TSH out. Check your T4, check your T3, and look at them in relation to each other. If your T4 is high and your T3 is low, you got to bring that T3 up. Give them T3 or desiccated thyroid. This comparison of mortality and non-fatal cardiovascular events in adults with atrial fib versus with and without levothyroxine treatment. This was the Journal of Cardiology. They featured this study which compared patients with atrial fib who were on levothyroxine to patients with atrial fib who were not. They found that hypothyroidism is associated with a decreased cardiac function. They also concluded there was no significant increase in cardiovascular risk, which is always an argument when we have patients on thyroid. People just want to blame the thyroid. Well, you got them on that thyroid, and that's why they have the atrial fib, and that's just absolutely not true. It's pretty much the opposite. Levothyroxine, or T4 in itself, has been reported to be cardiotoxic. However, in the study here, they found no significant increased cardiovascular risk for levothyroxine treatment. And as far as cardiotoxic, I don't know what they mean by that. Okay, now here, this is, I apologize, some of my references that I don't see, but this one was a comparison of mortality, I say, of mortality and non-fatal cardiovascular events in adults with atrial fib versus without. And T3 after bypass was found to improve cardiac function. Remember that low T3 can lead to congestive heart failure. Furthermore, hypothyroidism is also associated with dyslipidemia, which is considerably improved by levothyroxine. So they actually found T3 improves cardiac function. Study population included all adults. There were 12,283 patients greater than 45 years old who were diagnosed with atrial fib. A significant association between levothyroxine treatment and lower mortality was found among women. Levothyroxine treatment was not associated with the risk of MI, ischemic stroke, or congestive heart failure. So this was a good study. It had 12,283 patients in it. And here in a large representative cohort, we found that levothyroxine treatment decreased the risk of mortality in women with atrial fib, which suggests that such treatment could be of benefit in this setting. So T4 decreased the risk of mortality in patients with atrial fib, but also so did T3 in other studies. Subclinical hypothyroidism. Subclinical hypothyroidism is found to be associated with an increased total cholesterol level and LDL with subclinical measures of cardiovascular function. Higher TSH levels are associated with increased body mass index, so you're gaining weight. But do we give thyroid for weight loss? Oh no, that's absolutely frowned upon. But if you have a low thyroid level, your BMI goes up and you get an increase in waist circumference, which, as we know, is a danger spot. Elevated levels of leptin, which are found in obese patients, are another potential cause for high TSH in patients with obesity. So obesity and thyroid are actually tied together very strongly. Yet, for some reason, the medical community frowns on giving thyroid for weight loss. And I don't want to go there. I do not give thyroid for weight loss. But if you have a low thyroid level, you're going to gain weight. And if you have a low thyroid level, you can go on diets, you can go on intermittent fasting, you can go on phentermine, you can work your ass off in the gym, and guess what's going to happen? You're going to gain it all back if you don't correct the thyroid. So you have to correct that thyroid level in order to, reap the benefits of all your hard work. Current medical issues reported subclinical hypothyroidism is associated with elevated cholesterol and measures of cardiovascular disease. So you have all these different journals who are saying the same thing. So in current medical issues, they're saying it too. Also that hypothyroidism or high TSH are associated with an increased BMI and waist circumference. They also, like I said, reported an increase in leptin levels, infertility, spontaneous abortions, gestational diabetes, gestational hypertension, preeclampsia, and they recommended that thyroid be given to decrease the TSH. So infertility is a big problem when you have patients who have a history of infertility or miscarriages. That is something that I always check on registration when they first come in. They wonder why I ask all these crazy questions about menstruation and how old were they when they started having cycles, and what's their pregnancy history, and it backs up the diagnosis of hypothyroidism and shows the history of it. This is so important. All these women who will go out and spend a fortune on fertility drugs and getting tested in vitro. And it's just a shame that, a low dose of thyroid could change their whole world. The great masqueraders of depression, anxiety, and low energy. Okay. Abnormal thyroid levels are very common, and screening is essential. I can't tell you how many patients have depression, anxiety, and fatigue with subclinical hypothyroidism. Treatment is extremely effective, but the patient must realize it can take 2 to 3 months to kick in. Usually I give them 3 months. If they're not feeling better in 3 months, we got to make a change. Also, a total testosterone can often be normal, even when the free testosterone is abnormal. So, testosterone um, being a hormone, thyroid being a hormone, they kind of run hand in hand sometimes, especially when it comes to depression and motivation, lack of motivation, I should say. So this article talked about long-term augmentation with T3 and refractory major depression. I know in WorldLink, uh, Neil has went over this many times and shown studies where thyroid is used in extremely high doses sometimes for depression. And T3 is definitely something that needs to be looked at. The addition of T3 is one of the most widely studied augmentation strategies for refractory depression. And that's where a lot of times we get the desiccated thyroid, using desiccated thyroid so much. It does work. I've taken hundreds and hundreds of patients off antidepressants within 3 months of getting them on thyroid. Their sleep is better. Um, their mood is better. They just feel 100% better. Long term and high dose augmentation with T3 for refractory unipolar major depression was studied. Now, the average dose in the study that's mentioned here was 80 micrograms. T3 commercially comes in 5s, 25s, and 50s. I've rarely ever went over 100 mics. Patients do really well with it. I think, once again, that balancing your T4 and T3 is extremely important. I don't think that one is necessarily more important than the other. I think they're both very important, and we need to supplement and get these levels optimized in the upper third of the range. But T3 may be successfully employed as a long-term treatment, augmentation of major depression. Thyrotropin levels and risk of fatal coronary heart disease, the Hunt study. Now, Dr. Roger goes over the Hunt study ad nauseum, and it's something that you really want to learn. But they talk about thyrotropin levels within the reference range, and still associated with coronary heart disease mortality in women. The results indicated that relatively low but normal thyroid function may increase the risk of fatal coronary heart disease. And that's the whole thing. Most patients fall in the normal range. And there really and truly, there is no normal range, okay? It's a bell curve. I've worked in the labs throughout going to school, and I will tell you that the bell curve is there. And so who gets their blood work checked? For thyroid, people with thyroid symptoms, okay? So people with thyroid symptoms get their blood work checked, and you fall in normal range with everybody else who has thyroid symptoms. So is that really normal? So whenever we talk about clinically normal thyroid function, I kind of laugh about that. There is no normal. And let's get you up into the higher end of the range where symptoms disappear, because heart disease is a problem. And like we're saying, there are many problems with subclinical hypothyroidism, even if you're falling in the normal range. T4, T3 ratios, there's a lot to be said about that, but some people put more value on it than others. I definitely look at the ratio between the two of them and try to balance them out. And in this study here, they looked at free T3 and free T4 ratios and associated with acute MIs. The study aimed to assess the prognostic performance of T3, T4 ratios and predicted long-term prognosis in euthyroid patients. And I think that's a joke. With acute MIs undergoing percutaneous coronary intervention, PCI. And basically what they were saying is low thyroid levels are an increased risk of mortality after an MI. So, you know, we want to get those thyroid levels up to help prevent death. That's pretty easy, right? Prognostic performance was similar to the Gray score, and also improved its prognostic performance, Grace versus Gray score, free T3, free T4 ratio. In conclusion, euthyroid patients with acute MI undergoing PCI, the ratio was an independent predictor of 1 year all-cause mortality. So free T3 levels and global registry of acute coronary events, risk score on predicted long-term major adverse cardiac events, and STEMIs, patients undergoing primary PCI. Okay, this study aimed to investigate the combined values, and you know, same thing. The lower the score, the lower the levels, the higher the risk of MI. This was a study in 2018, and like you can see, it shows that the low thyroid levels are a strong predictor of cardiovascular, poor cardiovascular outcome. So just can't stress enough. This is the free T3 and global registry of acute coronary events. Same thing. Low thyroid levels are a strong predictor of poor cardiovascular outcome. Subclinical hypothyroidism is associated with cardiovascular risk factors such as dyslipidemia, strokes, heart attacks, and increased mortality. Where do you want your numbers to be? Also an increase in blood pressure, systemic vascular resistance, arterial stiffness, sorry about the misspelling there, atrial fib, and congestive heart failure, associated with metabolic syndrome, depression, anxiety, poor energy, hyperprolactemia. And remember, I talked about men having, you know, all the erectile dysfunction there. Also associated with rheumatoid arthritis and other autoimmune disorders, increased risk of miscarriages and premature births. Why would we not want to treat? And when the board comes after you and says you put your patient at risk for, you know, giving them a thyroid, it just makes me sick to my stomach, because we're putting these patients at risk by not treating them. With all the risk factors associated with low thyroid levels, I'm gonna steal Neil's line. Where do you want your levels to be? I mean, this is just a no-brainer. The TSH is totally unreliable. It does not, I repeat, it does not correlate with hypothyroid symptoms at all. I actually wrote a letter to ACE. I wrote a letter to American Thyroid and several others, and said, I can't find the studies where the TSH is shown to correlate. Can you please help me out? And every one of them responded with, I'm sorry, I don't think I can help you. And they can't help me because there are no studies that show it. This was a letter concerning the publication back in 1974 by an endocrinologist. And say, it appears that laboratory medicine has overcome clinical medicine in diagnosis and treatment. Whatever happened to the patient? Nowhere in their article do the author, this was in response to an article that's written, there's nowhere in the article do the authors mention their patient's clinical state. You can see this doctor is obviously frustrated. And D, the title of the article suggests they're treating the disease, not the patient. And this is what it's come to. We're treating numbers and not the patient. And we need to flip that. We need to be treating the patient, not the numbers. The numbers are simply a guideline to tell you what's low and where they are in relation to each other. And as he goes on to say, when our patients complain of continued dry skin, lethargy, and puffiness of the face and hands, and when we find continued slightly prolonged ankle jerk times, should we tell them not to worry because their laboratory numbers are normal? And of course, that is what happens. Although we attempt to suppress TSH to normal or undetectable levels, we adjust the dosage of T4 to the patient. We question a cost versus a benefit to the patient of adjustment of the lab values. I just want to say, the goal is not to suppress the TSH, in my opinion. TSH suppression is going to occur when you give them an adequate dose, but that's not the goal. The goal is suppression of the symptoms. He again goes on to say the conclusions seem to be based exclusively on blood chemistry, and the reader does not learn about the clinical status of the patients. And in his experience, clinical data is more important with the blood chemistry values. I see currently patients with normal serum T4s who still have signs of hypothyroid, and we all do. So, and this endocrinologist here is talking about he puts 200 to 400 mics or more of levothyroxine for satisfactory responses. So, I was saying earlier that it comes to 25s, 50s. Well, the authors recommended starting with, on this article that he's reading, 50 mics of levothyroxine a day and gradually increasing. There is no advantage to starting that low usually. You want to, get the levels up, get them up quickly, as quick as tolerated, and titrations are an easy way to do that. So you titrate, you start off with, let's say, if you want to use the 1.6 micrograms per kilogram, you could start off with that and then, go up every 2 weeks or monthly, whatever you're comfortable with, until the patient's symptoms disappear. If they start to become anxious, nervous, jittery, or have tremors, you just back down on the dose. Just some references here. I want to thank you for taking a little bit of time and listening to us. And when we talk about the standard of care, I want to leave you with this impression. The standard of care for almost 3 decades, was the transorbital lobotomy. Dare to make change. All right. So I don't know anybody doing this now, but this was a standard of care. So just think about that. When someone says you're not following the standard of care, okay, well, I would question it. Thank you very much.